Thank you very much. I thank you for the invitation to speak today. And I was actually really surprised to learn that SAGES is interested in learning anything about rural surgery, because prior to me becoming a rural surgeon, I had no access to any information. So, disclosure, I have nothing to disclose. I'm going to start off by telling you a little bit about rural surgery, because I can't really discuss the business of it if you don't know what it is, and I definitely had no idea. Suffice it to say that when I started looking for jobs after my residency, I didn't think I was going to go into rural surgery. I knew I wanted to be a community practice surgeon. I knew I wanted as much autonomy as possible, because I was really tired of my attendings by then. And this opportunity presented itself because they heavily recruited me. And I've now been there for 16 years, and I'll go a little bit into my practice. The first year was extremely hard, and hopefully some of the information I show on my slides will explain and help you sort of avoid some of the pitfalls I did, but overall, I really do love my practice. So, rural surgery. 15% of the population, so 46 million people, live in rural communities. And it actually matches up pretty well because 20% of all hospital beds are in rural hospitals. The problem is 1/3 of rural hospitals are still searching for a surgeon. So if you can imagine that there are over 900 counties, not cities, but counties in the United States where they do not have a general surgeon in the entire county. So some definitions. Small rural community is less than 10,000 people. A large rural community is about 10 to 50,000. So what makes rural surgery different? First of all, greater reliance on federal and state payers. Translation, Medicaid and Medicare. 1/3 of my practice is Medicaid, 1/3 of my practice is Medicare, and 1/3 of my practice is HMO and PPO. And I'll talk about it a little bit later, but I do have very good HMO PPO contracts, because unlike being in a big city, a solo practitioner has absolutely zero negotiating power. In a rural environment, you actually have a ton of negotiating power. Patients will frequently present with multiple comorbid conditions for which they have not received enough treatment. What do I mean by that? A lot of my patients come in with a BMI greater than 35 who tell me that they have no medical problems because they don't feel bad and they don't take any medications. When I do their pre-op for surgery, first thing I find out is they have diabetes, they have hypertension, and they have multiple other medical problems and frequently need a cardiac evaluation before I can even take them to the operating room. Those of them who actually go and seek treatment are, for lack of a better word, really non-compliant. They decide which meds they want to take, the frequency they want to take it, and again, if they don't feel bad, they don't necessarily go back to their physicians for follow-up. What means is that your patients wait longer before seeking medical and surgical treatment, and a lot of times they use the emergency rooms liberally. So as a rural surgeon, you do quite a bit of what's considered acute care surgery, and you get to see quite a few disasters where people come in with ruptured appendices, ruptured colons, ruptured perforated gastric ulcers, where their abdomen is just a catastrophe. So this is where I work. El Centro is the county seat of Imperial County. You see the red arrow pointing to that little tiny dot that's not near any other dots? That's El Centro. The closest city to the west is San Diego. It takes 2 hours to get there, and you have to go through a mountain pass, which during the wintertime sometimes closes down. And the closest city north of us is really the Palm Springs area, which also takes about 2 hours to get to. I didn't realize you could live in Southern California and actually be in a rural community, but there I am. The population of my town of El Centro is 45,000, so it qualifies as a large rural community. We have one other hospital in our county that is 20 miles north that has 26,000, and my hospital is a 161-bed hospital, but we can only normally have about 100 patients because we don't have enough staffing in order to cover it all. So, a lot of times when we talk about rural surgery, we imagine cows, sheep, lots of agriculture, and all that exists in my community. Dr. Susan Hom, who is one of my friends and colleagues in the community, she works at the other hospital, graciously provided a picture, and this is her son's calf, and she also raises chickens in her backyard. I do not. But this is also Dr. Hom when she's in clinic, with her tiara and her Louis Vuitton bag, to show you that rural surgery is not just about the agriculture and being in a remote area, but you can actually live your best life if you choose to. So I want to go a little bit into what we learn in residency and what we don't before I even talk about the business of surgery. Because a lot of these things I had no idea going into my first job. And this is what made the first year so challenging. In residency, you learn what you can do. And it's great. You learn how to do big cases. You learn how to take care of the patients in the postoperative period. You learn how to negotiate and discuss with your attendings and other residents in other fields. What you don't learn is what you should do. And it doesn't, what that means is just because you have a skill level and you were trained well in residency, which most of us were, hopefully all of us, it doesn't necessarily mean you should if your hospital system can't support the care of that patient, whether either intraoperatively or postoperatively. When I graduated residency, I thought I could do Whipples because I did them. I loved the operation. I was excited I was going to bring a Whipple program down to this little town. And within a week, I was like, oh, there's no way I can do a Whipple because if I can get them off the table, I definitely don't have the oncology, I don't have perioperative, I don't have anyone in the ICU that can help me take care of this patient. It's interesting though, because I met another rural surgeon here at Sages just 2 days ago, Dr. Straub, who works in Washington, and she actually told me that 6 months after starting her rural practice up in Washington, she actually did start a Whipple program, but it took that long because she had to figure out how to make all the ancillary support make sense. You couldn't just walk in and say, hey, I can do a Whipple. In residency, you learn how to do chief level cases. We learn how to do Whipples, esophagectomies, all the advanced cases that we love to do. And what we don't learn in residency is if you're not gonna go into a fellowship or you're gonna go into an academic institution, if you are gonna have a more broad-based community practice, especially in rural medicine, you should be really focusing on those intern cases during your chief year. You should go back and do as many hernias as you can, both open and laparoscopic. You should go and try to do every single on-call gallbladder because that's really what we see a lot of. In residency, I'm sure most of us have fond memories of the scrub tech or the circulator nurse or the ICU nurse who was actually instrumental in our training and taught us a lot of what we didn't know. And then you go into a rural environment and you realize they're not there for you anymore. Now you have people with high rates of turnover, very young in their experiences. They may have not done these bigger surgeries because it may have been years since they've been able to recruit a general surgeon. And so now you have to start gauging what can everyone else do. You're not teaching medical students and residents anymore. You're actually teaching your OR staff how to help you do the operation. What I miss most about residency is that working with specialists, picking up the phone, being able to call any of the other subspecialties, asking them about questions, having them come in on the case. Just to give you an idea, in my town, we got interventional radiology in 2018, and they leave the hospital at 5 o'clock and they're not available on the weekends. We don't have any subspecialists, and so there are quite a breadth of surgeries that they'll frequently ask me to do. And so fortunately, I have a network of people through SAGES as well as through my old residency program. And you get used to being the one that they turn to and not having necessarily a lot of other people to turn to, which basically means that it can also make you feel isolated and a little bit alone. In residency, we learn about partnerships. You operate with your attending or your fellow residents. You take other people through. In solo practice, in a rural environment, there's no backup, there's no first assists. It makes it especially difficult in California where scrub techs can't actually assist for you. You can place their hands and they can't even move a retractor. So you learn how to do things by yourself. And learning how to do colorectal anastomosis with no one else in the room, with one sterile hand and one non-sterile hand, was really challenging my first year. So let's go into a little bit about what it means to be a Renaissance surgeon. So when we think about Renaissance, you talk about many talents and areas of knowledge. And truly, historically, this was what was expected of people who went into rural surgery. And when I first entered El Centro, we had an older physician, 25 years my senior, and he actually did everything on this list. So unicorns do exist. I do not do everything on this list. Present day, surgeons can shape your practice, but you still require a great breadth of knowledge of surgical skills. Probably about 50% of my practice is minimally invasive. I do have not one, but 2 robots, and if anyone's interested in how we got them at such a tiny hospital, I'll go into it later. But I also do, in addition to laparoscopy, I do endocrine, I do breast, I used to do vascular, I stopped. I do some pediatric, I do a lot of hemorrhoid and pilonidal disease, as well as a lot of soft tissue, everything from necrotizing fasciitis, Fournier's gangrene, and a 9-pound lipoma that I took off of somebody the other day. So it's important that you know your skills, you know your limitations, and you know the limitations of the hospital and staff. And the one thing I sort of want to say is especially as a rural surgeon, to accept that sometimes you have to transfer the patients. A lot of the times you might have to transfer the patients, whether because you can't provide the quality of care that they deserve, whether the hospital doesn't have the resources for you to deliver the care that you want to, or worst case scenario, you have a complication and there's no one else to help you, you just need someone else to help you get out of a bad situation. And so I always like to tell young rural surgeons, number one, it's not a failure to transfer, and whenever I have the opportunity, I tell academic surgeons, have a little bit of patience and sympathy. It's not a dump, really and truly. Sometimes our resources are so limited that we just need that help in order to make sure the patient has a good outcome. So now let's talk a little bit about the business of surgery. There's two relationships you have to sort of negotiate. One is the business that you deal with the hospital, and the second one is the business as your own solo practice. So let's talk about the hospital first. As other speakers have already told you, you have to know what you're worth. In my hospital system, there's multiple models. So you can be employed by the hospital. You can be on a 1099 contract with an RVU model. I had an income guarantee in my first year that basically set me up for solo practice. And in all those situations, you have to know what to ask for. And sometimes that's not only the base salary, but they also went into the other things that you can negotiate in your contract. But also, the one takeaway for anyone who's looking at community practice or rural surgery, don't give away your call. It's one of the most valuable things that you have for the hospital. And the first thing I discovered is how much money they gave to locum surgeons, and that made my negotiations way better. You want to know how to ask for things, and you want to know what questions to ask. One of the things I tell people, and I'm going to start going a little faster because I'm running out of time, is never assume that every hospital should have this. It was one of the eye-openers going into rural medicine, that things that I thought were the standard of care, things that I saw everywhere in the hospital were not necessarily so in my hospital. And so having to advocate and find my voice took me about a year, and learning how to negotiate how to bring innovation into this rural community so that my patients would have better outcomes, and so the patients had the confidence that the care that they received in a rural environment was as good as they could get over in San Diego. More importantly, you want to make sure to always set boundaries and limits. And I'll tell you, the rural hospitals, they will try to get whatever they can out of you, and they'll keep asking for more and more until you finally learn how to say no. So if you want any type of work-life balance, because as a solo practitioner in a rural community, I don't have a lot. It was great that I get to come away to go to meetings, and this is actually my vacation for the first half of the year. And you want to make sure you sharpen your negotiation skills. I'm going to go through the last two just really quickly, because I know that we have other people who are going to be talking. Okay, thank you. You're gonna give me 2 more minutes, great. Okay, so part of the business of surgery for a solo practitioner. First and foremost, we know nothing about the business of surgery when you graduate residency unless you have a parent who has something to do with business or a CPA. So it's really important when you first start off to get a practice manager, because they will help negotiate a lot of the pitfalls for you. Everything from office space, how big of space do you want? Do you want something small that you're gonna outgrow and you're gonna have to expand, or do you want something big that's gonna cost you more money that you're gonna grow into? Contracts, not only with the hospital, but also with the insurance companies. And I will tell you, as a rural surgeon, you have a lot of negotiating power because they're really negotiating just with you. You want to make sure that you understand coding and billing. I went from doing my billing in-house to outsourcing it because it got to be too much. But you always want to know, because what your revenue stream looks like, and that's been discussed before. Staffing and payroll, referrals is a big deal. I literally, the first 2 weeks of my practice, went and visited every single PCP and pediatrician, shook hands, brought donuts, told them what I could do, and all of them, the first response was like, we can actually do this at this hospital? And I said, yes, we can. And then some things, even as simple as equipment and supplies, like, do you want to invest in a $50,000 ultrasound so you can do your own aspirations and biopsies in your office, or do you want to refer all these to the hospital? And these are decisions that you make as trying to develop your private practice. I'm going to finish the talk. Oh, one last slide, if I can get to it. Okay. One of the benefits of rural surgery that a lot of people don't know about is the public service loan forgiveness. And you have it on both a national level, which is the National Health Services Corps, as well as state-funded programs, being from California, the Stephen M. Thompson program. And what these programs do is they allow for loan forgiveness if you spend a certain amount of time in a rural community. And normally that's about 5 years. And I'll tell you that my one of my ER colleagues told me this year that he just celebrated his 5th year, that his entire $300,000 med school loan was completely written off and forgiven by the government as a result of him being there. So there is some benefit financially also, because you might be able to get your loans forgiven. And on a final note, by virtue of being a surgeon, and right now in my community, I'm the only surgeon at my hospital. We have 3 surgeons at the other hospital, so we are recruiting if anyone's looking. You will be asked to serve on committees and accept leadership positions. Pretty much from year 3 on that I was there, they kept asking me to take leadership positions. I didn't feel I was ready. Finally, about 10 years ago, so 6 years after residency, I was vice chief of surgery, then chief of surgery, chief of staff. I'm now the assistant chief medical officer of quality, and they just appointed me to the hospital board. I do feel that surgeons have a huge voice. We can affect a change once we find that voice, and the leadership opportunities are definitely there, and they want us to participate. Thank you so much.